La presentación de nuestro equipo directivo. Me acompaña el doctor Armando Félix, vicepresidente de México, el doctor Lengua Reyes, el doctor Muriano. La siguiente, por favor. El doctor Armando Fernández, el doctor Lachos Dávila, el doctor Francisco Solís, el doctor Ferran Guedea, el doctor Alejandro Santini, representantes de nuestras subregiones de la América Latina y de la península ibérica. Con mucho entusiasmo aceptamos iniciar la vida académica con este tema. La doctora Beatriz García es una conocida colaboradora en la formación de recursos humanos. Ella tiene todos los créditos en el manejo de malignidades pediátricas y ha tenido destacadas participaciones en los grupos cooperativos como el Grupo de Oncología Infantil y otros. Es un buen enlace para el ATRO en esta rama tan importante que es la radioterapia pediátrica. Entonces ella moderará y me adelanto a poder comentar que la modalidad será que las preguntas que deseen hacer las pueden transcribir en el chat y nuestra moderadora podrá elaborarlas al final de la presentación del doctor Luis Constín. Quiero agradecerles a los más de 520 participantes que se han inscrito y que se están incorporando en estos momentos, porque eso nos anima y nos compromete para el plan académico que tenemos para reforzar la actividad académica de nuestro recurso humano en el continente y en la península ibérica. Son 16 países los que se han involucrado en esta actividad y estamos muy, muy contentos de poder compartir estas actividades y certificarlas a través de una cortesía del Consejo Mexicano de la Certificación. Esta actividad tiene 4 puntos. Agradezco la gestión de nuestro vicepresidente, el doctor Armando Félix, y del Consejo Mexicano, por supuesto. Y creo que estas son alianzas que nos mueven y nos comprometen a dar lo mejor de esta asociación, a la que todos están invitados a participar y tienen también la presencia de nuestra asociación ya en redes. Tenemos esta actividad transmitida en vivo por YouTube. También se pueden colgar a quienes no han tenido oportunidad para poder tener esa red a disposición. Estamos en Twitter, en Instagram y comenzamos a tener la presencia académica que necesitamos para que avancemos juntos en el desarrollo en la fecha de esta revisión. Armando, sin más, te cedo el micro, por favor, para que podamos dar inicio a esta actividad.
Muy buenas tardes, Gustavo. Gracias. De verdad estoy muy contento. Tengo el gusto de interactuar el día a día con todos los compañeros de Latinoamérica y de España, con una interacción totalmente académica y seré muy breve en cuanto a instrucciones de esta sesión. Tenemos la opción de closed caption para poder ver la traducción en subtítulos. Y como ya dijo el doctor Gustavo Sarria, tenemos la opción de transmisión en YouTube. Las preguntas solo se dan en el chat. El doctor tiene un tiempo muy breve. Si hay necesidad de preguntas, daremos el mail del doctor Constín para que se le hagan las preguntas directamente. Y sin más preámbulo, le doy la palabra a la doctora Beatriz García, quien es una radiooncóloga pediatra que ya tiene un renombre muy importante a nivel internacional y que es la directora de Teletón en Querétaro, México. Adelante, Beatriz.
Muchísimas gracias, doctor Félix, doctor Sarria, por la invitación y de verdad que para mí es un honor presentar al doctor Luis Sandin Constin. El doctor es yo le dije hace un momento, un rockstar en la radioterapia pediátrica. Él tiene certificado por la Junta de Pediatría, de Oncología Pediátrica y de Radiooncología. Es un experto en todos los cánceres pediátricos y sobre todo en la supervivencia en relación a efectos agudos y crónicos. Es parte del comité de la supervivencia del COG, también de la clínica del Astro, de la clínica de efectos tardíos del COG, es asesor senior del comité de linfomas igual en el COG, es parte del comité directivo del NCI y del Childhood Cancer Survivorship. Ha escrito, ha sido autor, coautor o editor de más de 50 capítulos de libros. Y la realidad es que a él lo rige mucho su calidad como persona, como médico, y ha sido uno de los principales motores de la investigación en radiooncología pediátrica. Me gustaría dejarlos inmediatamente con él, solo mencionando sus palabras, en donde dice que para el sobreviviente de cáncer, el mundo está lleno y cada día es una celebración para el médico. Cada paciente es una inspiración para la persona que lucha contra el cáncer. Cada día es precioso y debe ser enfrentado con valentía. I am very happy to introduce to you to Dr. Constin. Please, Dr. Constin, share with us your talk and please give us your expertise. Thank you.
Well, I could not understand much of the introduction, and I'm sure that I have too much to live up to, and you were more than generous. But I so much appreciate having this opportunity to share with you some of my research on the long-term side effects in children. And I, in particular, want to thank Dr. Robles for helping me to get to know the Latin American Society of Radiation Oncologists. So these are my two granddaughters, and they remind us that we are all children masquerading as adults. So stay young at heart. So this talk is on Pentec, which is pediatric normal tissue effects in the clinic. It's an international collaboration, and I will explain to you what we have done. This shows the website at the very bottom of this comic. We are a group of about 150 investigators trying to understand the vulnerability of children to the cancer treatments that we give. There has been very much in the news about the long-term side effects of radiation and chemotherapy. And so the question is, can we reduce the risk of premature mortality and serious morbidity and improve quality of life? And so you can see some of the publications that have been coming out, and it's even in the newspapers, young survivors in a deadly war. So we need to win the war. So here is the outline for this discussion tonight. What is Pentec? Why are children vulnerable? What is the history of late effects research? What are some representative results? And how do we apply the data? And what are some of our future directions? And so some of the earliest knowledge of the effects of radiation on the normal tissues was about a century ago, in the early 1900s. Edith Quimby showed that if you give the higher the radiation dose, the more likely you caused skin reactions. So there is a long history now of studying the side effects of radiation on children and adults. And in 2007, this issue of our major radiation journal was published on something called the Quantec, which studied the long-term side effects of radiation in various tissues in adults. I was on the steering committee for this project, which went from 2007 to 2010. And then in 2011, we began to study hypofractionation, SRS, SBRT, as you know it, in select organ tissues, including, for example, the eye and the spinal cord. And that was published in 2021. And then in 2013, I started Pentec, which looks at different normal tissues in children. And this is what we will talk about today. I will just say that one of my professors, when I was a medical student at Johns Hopkins around 1970, said, diligent scholarship and intellectual sweat can grind chaos into useful patterns of complexity. And I think this is sometimes what we have done when trying to understand all of the data. So what is Pentec? We are a group of physicians, radiation and pediatric oncologists, subspecialists like cardiologists, orthopedics, physicists, epidemiologists, critically synthesizing data. And the goal is to develop quantitative, evidence-based dose volume guidelines as impacted by developmental status. So how the child develops, to inform radiation planning and improve outcomes. And then we had some other goals. Now, all organs in a child's body are developing, of course, but they develop at different rates. And this is very much important in trying to understand the long-term side effects of radiation on these organs. So the brain, as you know, develops quite rapidly in the first years of life. The lymphoid tissues develop in the pubertal years. The musculoskeletal tissues, this is actually, we have grouped all of the different organs into these 4 different categories. Most of them follow the example of the muscles and the bones. For example, the heart, the intestines, the kidneys, most organs, there's a rather rapid spurt in the early years of life, and then it slows down, and then they begin to rapidly again develop during the pubertal years. And then, of course, the ovaries and the testes don't really develop fully until the later years. And so what is the relevance of developmental dynamics on organ vulnerability to radiation toxicity? So what I mean is that age at the time you treat a child is going to be critical to whether a particular organ is affected by radiation and how much it is affected. But age is a surrogate for developmental status for the reasons I've just mentioned. Since different organs develop at different rates, some early in life, some later in life, age is just a surrogate because radiosensitivity changes with developmental status. Also, the cell populations in an organ are functionally heterogeneous. So for example, the kidney, in the pelvis of the kidney, there are collecting tubes. Those are resistant to radiation. But in the cortex of the kidney are the nephrons and the glomeruli. Those are eloquent and they're sensitive to radiation. So even within an organ, there are different areas of differential sensitivity. And then there are many other factors that contribute to long-term side effects. And for example, the sex of the patient has an impact. We talked about growth and development, but obviously the chemotherapy and the radiation, but also if a patient has a bad infection and that damages the kidneys, maybe they can't tolerate chemotherapy well. So lots of different things cause long-term side effects. Now most of us or all of us are radiation oncologists, and the type of radiation we use is very important in the long-term effects of radiation. So here you see 3-dimensional conformal radiation on the left and volumetric modulated arc therapy or intensity modulation in the middle, and intensity modulated protons on the right. And the colors relate to different toxicities, heart problems in the blue and the purple, and cancers like lung cancer in red, thyroid cancer in green. Some of these long-term side effects are deadly, no matter how infrequently they occur. So lung cancer, which is a deadly problem, and you can see that there's about a similar amount of it occurring after intensity modulation and 3-dimensional. But for example, heart problems, there would be more concerns, more likelihood of it shortening the years of life using three-dimensional. So the more sophisticated our radiation gets, the less likely we cause these problems. And this graph is showing you how these problems caused lost years of life. So what does Pentec include and how did we go about it? So Pentec took us a decade, but the first 2 years were devoted to developing the methods. And in that issue of the journal that I showed the cover of earlier on, there are 31 reports in that issue of the International Journal of Radiation Oncology. And we have a series of introductory reports talking about methods. And then we have 19 organ reports on all the different organs, also second cancers and reirradiation. Each of those papers has different parts to it in terms of endpoints, anatomy and development, how you define volumes, and all the information about radiation doses. And then we have some reports at the end, which are called vision reports, and they look to the future. So if you have that journal or you can find the link to it, then you see all these reports. We identified and selected evidence for each of these organs. We extracted data from the different reports that we found. We described and synthesized the data, and then we judged the data with expert opinion and analyses, and then we make some conclusions and recommendations. Now, it's difficult to do this. It's difficult for many, many reasons to look at a certain organ and look at the reports on that organ of late effects and understand what it is trying to tell you. Because the radiation types might be different, protons or photons or electrons. In the report, are they talking about the prescribed dose or the actual measured absorbed dose? If it's an organ that's being treated, like we talked about the kidney, is it the whole kidney or just part of the kidney? And what part of the kidney? How is the dose distributed? What is the fractionation? How old was the patient when they were irradiated? How old were they when the testing was done? And sometimes the reports give the mean age, sometimes the median, sometimes they give a range, sometimes they bin the ages into groups. Sometimes they don't describe if there was a transplant or what the chemotherapy was. How long is the follow-up? And how complete is it in terms of how often it assessed the side effects of treatment that might not have occurred for many years? And then how did they define the endpoints that they were trying to investigate? For example, if they were investigating hearing, what toxicity scale did they use? Because different toxicity scales are used in different places. And so it's very complicated to try to understand the information. So now what I'm going to do in the next half hour or less is show you some of the results of our investigations into some of these different organs. First of all, I will tell you, in that journal that I have been alluding to, the one that was published, it was published last June of 2024, on the whole Pentec project. In that, there is the second paper which I wrote is called the User's Guide. And in the User's Guide, there is a several-page table, and that table summarizes all of the different results. It's a summary table for everything. For example, it will list the organ, like the brain, and then it'll say, was it the whole brain or part brain? And then what did we study? In this case, maybe IQ less than 85. That was what we studied. And then how much radiation to what percentage of the brain caused what risk for that endpoint? So 51 grade at 10% of the brain, 20% risk for an IQ less than 85. And then we talked about the impact of age and whether chemotherapy might have been relevant, like methotrexate. So if you find that report, you will have a summary table. So now I'm going to go into some of the organs. This is the CNS. And only for this organ, I'll show you sort of what we did. For this organ, we looked at 4,000 abstracts. And out of those abstracts, we ended up omitting most of them for different reasons. They didn't have the information for this reason or that reason. We ended up being able to analyze 43 of those papers. And then in 31 of them, it gave us adequate information on intelligence quotient or processing speed of information. 11 gave us information on necrosis. So what you see here is the risk for an IQ less than 85 on the horizontal line and the equivalent dose in 2 gray fractions that causes the risk. And any studies that included methotrexate, which can damage the brain, those are in red. And so you can see as the radiation dose goes from 20 to 30 to 40 gray, the risk of the IQ being less than 85 continually increases. And here you can see how important the volume is. In the red is 10%, and the gray is 50%, and the purple is 20%, and the green is 10% of the brain. So this is the dose associated with the 5% risk of an IQ less than 85. If you irradiate 10% of the brain, 36 gray causes that risk. But if you irradiate the whole brain, half that dose, 18 gray, causes a 5% risk of an IQ less than 85. So the more brain you irradiate, the lower the radiation dose, it will cause problems, as we all know. But this shows you the data. And this is showing you the impact of methotrexate. So methotrexate, you see in green at the bottom here, was similar to about 6 gray of radiation to the whole brain. So if we have a child who, in red here, who had an IQ in the hundreds and was irradiated at the time of they were 5 years of age, and then they got 30 gray of radiation, their IQ will drop to less than 95. However, if they also, this lower blue line shows that same group of children irradiated when they were 5 years of age. If they got methotrexate, their IQ actually started somewhat lower, and it drops much more due to the effects of the methotrexate. And this is true for no matter if you're irradiated at any age you're irradiated. And this is showing you necrosis. So you all know you get brain necrosis. You can see it on imaging. Sometimes it causes symptoms. And you can see here the risk for necrosis on this left side goes up as the radiation dose increases. It doesn't really occur very often until you exceed doses of 50 or 60 or 70 gray. I lost the sharing. What happened? Here. Okay, I got it. Okay. Hopefully, can you all see my screen? Can you see the graph? I hope. Interrupt me if you're not seeing the graph.
No, we can see it, doctor.
Okay, good.
You can continue. Thank you.
So this shows you the red are protons, and they were really not different whether you use protons or photons, because the radiation doses are pretty similar. The volumes might be a little bigger with photons than with protons. Okay, now what about cerebrovascular, which are like strokes, when you get a stroke? There were 100 patients who had vasculopathies, strokes of different sorts. And if we look at the attained age of 45, they were irradiated when they were children. By the time they were 45 years of age, there was a 13% compared to 1% in the general population, 13% likelihood of them having a stroke by the age of 45 relating to the radiation. And you can see that the less if the radiation dose is lower. And this is showing you a graph of that data, but I'll show it to you in the next slide on in a different way. But by the time you're 45, of course, you have many years since the treatment, and you're more likely to have a stroke compared to if you're only 35 at the time you were tested. But here you see those patients who got the higher radiation doses in green, more than 10 gray, had a higher likelihood of a stroke going up on this left arm axis compared to if you got less than 10 gray. 1 to 10 gray, much a lower incidence of stroke. And then now we'll talk about hearing. I will interrupt myself to mention that I'm giving you all this information about the long-term side effects of radiation in children. But I want to be quite clear. The importance of doing this is so we understand what these risks are. But all of us are doing everything we can to treat these children and to cure these children of cancers, of deadly cancers. They need our treatments. They need our compassion. They need our dedication to doing what we can to cure them. And we try to minimize. We try to minimize the risks of long-term side effects by understanding what they are and doing what we can to avoid them. Okay, now back to showing you some of these results. Now I'm going to show you sensory neural hearing loss. So it's less than 5% with a mean radiation dose of less than 35 gray, but it increases to about 30% after 50 gray. You can see how the likelihood of hearing loss going up on the left increases as the radiation dose goes up. This is one of the first times that anybody has demonstrated how important it is how old you were when you got the radiation to your cochlea, to your ear areas. So you can see here that for children less than 5 years of age, in this first, you can see this first spike, they have a 25 to 40% risk of hearing problems compared to older children, where it drops down to about 10%. And it took about 3.5 years for hearing loss to develop. So that's, even if they don't have hearing loss at 1 year, it doesn't mean they're not going to have it later on. So you have to test them for their hearing, because if they lose hearing, then they don't do very well to learn, and they don't do well in school. And this is showing you that the radiation and chemotherapy cause different types of hearing loss. Chemotherapy causes high frequency hearing loss. And so in the box here, these boxes have to do with chemotherapy and radiation. You have more hearing loss with them, and they are usually high frequency. But radiation can also cause low frequency hearing loss. So the blue and the green are the low frequency hearing losses, and that's more from radiation, whereas the chemotherapy is more causing the high frequency hearing losses, which are more relevant to understanding speech, as it turns out. Most toxicity scoring systems don't take into account low frequency hearing loss. And here you see the importance of platinum. Cisplatinum can cause significant hearing loss. And in fact, it's just as important as radiation. And so here, the upper solid lines are children less than 3 years of age at the time they got radiation. And the dotted line, and what you can see here is the dotted lines are children who are more than 3 years of age. So they're underneath because they have less hearing loss, because on the left here is the likelihood of hearing loss. So if you got 300 milligrams of cisplatinum per meter squared and you were less than 3, this top red line shows you the likelihood of hearing loss. So cisplatinum increases the risk, and we think about 300 milligrams per meter squared is about the same as 7 gray of radiation. Here's thyroid. Here you can see that there's about a 50% risk of hypothyroidism after about 30 gray. So you can see it on this graph. As the radiation dose to the thyroid gland increases, then the probability of hearing loss up here on the left also begins to increase. And it's about 50% risk at about 31 gray or so. Here, what you can see is the difference between compensated and uncompensated hypothyroidism. So, for example, as you know, if your TSH, your thyroid stimulating hormone, is high, but your free T4 or regular T4 is normal, that's compensated. That means your pituitary is secreting TSH, and it tells the thyroid to make thyroid hormone, and the thyroid gland can keep up. So after 10 gray, there's a 12% risk. After 20 gray, 25% risk. After 30 gray, about a 44% risk. However, about a third of the time, a 4% after 10, 7% after 20, 13% after 30, a third of the time, the thyroid gland can't keep up anymore, and the free T4 or the thyroid hormone level in the blood drops below normal, and that's uncompensated. And this is a very interesting finding. The first time this has really been nicely shown. It turns out that girls are more likely to have hypothyroidism than boys, and older children more likely than younger children. So as an example, I'm not going through all the data because you would all be bored, and I'm just trying to do my best to make the important points on these different slides. But here what you can see, for example, is a female who got 30 gray has a 53% chance of having hypothyroidism. If they got 40 gray, almost 80% chance. But if they're a male, then much less, 31% and 47%. And if they're younger, they still have these risks, but less than if they were older. Now we'll talk about the eyes. So the most important toxicities for the eyes are effects on the retina, retinopathy, optic neuropathy, and cataracts. And so these are the amounts of radiation corresponding to a 5% risk of these problems or a 50% risk of these problems. So for example, damage to the optic nerve or to the retina, it's about a 50% risk at doses in the mid-60s. But it's only about a 5% risk for retinopathy at 40 and optic neuropathy at 57. So really the optic nerve is pretty good if you stay under 55 gray. But you try to keep the retina under about 40, but still it usually will be okay. Once you exceed 60, that's when you have problems. For cataracts, I'll show you on the next slide. It makes it easier to understand, but a doctor, an ophthalmologist, can diagnose a cataract at a very low radiation dose, like a 50% risk after 9 gray. Whereas a patient the patient will not notice a cataract until the radiation doses are much higher, because then they're not seeing very clearly. Here you can see the graph showing retinopathy, damage to the retina. So you can see the 5% and the 50% and the 5% risks after these different radiation. As the radiation dose increases, that's on the bottom line, the EQD2, as it goes from 40 to 50 to 60 gray, then the risk of retinopathy begins to increase, but very little under 40 gray. And this is the cataracts that I was trying to show you. So on the bottom is the radiation dose to the lens, 10, 20, 30 gray. And up on this horizontal line, this vertical line, is the likelihood of a cataract. And an ophthalmologist will see a cataract after 2 or 4 or 10 gray, very commonly. But the patient won't notice that. patient won't notice something until the radiation doses have gone beyond 15 or 20 or 25 gray. Then the patient may begin to notice something. Okay, now what about the kidneys? We've talked a little bit about the kidneys when I was just giving the introduction. What we're now looking at is the likelihood of severe renal toxicities and after radiation for total body irradiation or for Wilms tumor. And the measurement is the glomerular filtration rate less than 60. And that is National Kidney Foundation stage 3 damage. So the NKF has a staging system. Greater than stage 3 damage is after less than, is when the GFR drops to less than 60. And this is the likelihood of that, the percentage likelihood of severe toxicity, the normal tumor complication probability on normal tissue. So what you see here, as the radiation doses begin to increase above 15 to 20 gray, that's when you begin to see a severe renal toxicity. And here we're looking at hypertension. Hypertension is also, as we know, a very, very important side effect, because if you become hypertensive, it affects your heart. It might increase the risk for many other metabolic problems. And the risk for hypertension also begins to go up after doses of about 15 to 20 gray. That's when you begin to see increased likelihood of hypertension. And then this is a very interesting finding. So what I've summarized all the data here. In the top, this panel is Wilms tumor, whole abdomen, 10.5 gray. And you can see the likelihood of severe toxicity is very small, 1.2%. Mild toxicity, which isn't too important, 7.5%. If we look at 12 gray total body irradiation, then severe toxicity is still quite low. A little more. But there are two TBI doses, 12 gray, but in this middle one, it's 1.5 gray twice a day for 4 days, 8 doses, 8 doses of 1.5 versus 6 doses of 2. And interestingly, 6 doses of 2 was more damaging than 8 doses of 1.5. So this is an example where lower fractionation is less likely to cause damage. So you can see mild problems, 16% mild kidney problems after 2 gray 6 times versus 11 to 12%, 1.58 times. So this is the first time we've been able to show that the size of the fraction per total body irradiation may make a difference. Now, some of us are going to be using volumetric modulated arc therapy for total body irradiation. We're beginning to use it here, which allows me to reduce the dose to the kidneys and to the heart and so forth very selectively. And this is a very important slide, because what this is showing you is chemotherapy is actually more damaging than radiation. So this solid line at the bottom is if you give more than 10 gray to 10% of the kidney. But you can see here, this is after ifosfamide, this top graph, and after cisplatinum, this is the risk of damage. And you can see ifosfamide, cisplatinum, carboplatinum are causing more damage than radiation to a portion of the kidney. Next, this is now looking at, we're going to talk about the ovaries briefly. So we're going to talk about the likelihood of ovarian, this is acute ovarian failure, when the child loses function of the ovaries. And I'll remind you that early in life, you have more oocytes than you do as you become a teenager and as you become an adult. So the older you are, a 20-year-old is more likely to have damage from any particular radiation dose or from chemotherapy than will a younger child. And in this situation, we were measuring the chemotherapy in something called cyclophosphamide equivalent dose, because cyclophosphamide hurts the ovaries and similar type chemotherapeutic agents. So for example, if you have a cyclophosphamide equivalent dose of greater than 30 gray, it really doesn't matter what radiation dose you use. Those patients are all going to have problems with acute ovarian failure. But if you don't have any chemotherapy, then a 20-year-old at a low dose of only 2 gray will have problems, whereas a 1-year-old could tolerate 7 gray safely. And if you have an intermediate amount of cyclophosphamide equivalent, then similarly. And this is this is graphically shown here. And on the bottom, for example, this blue dotted line is a 20-year-old who got 30 grams per meter squared of cyclophosphamide, and you can see that they have a very steep likelihood. The probability of ovarian failure is quite high. And it's less if they have less cyclophosphamide, and it's less if they are younger. And this is showing you something similar for premature ovarian failure. So these are children whose ovaries work, but they stop working when they're pretty young. In other words, they undergo menopause at a young age. And this is showing you the age at menopause, 20, 30, 40, and the likelihood. And the likelihood is going to be higher after higher doses, like 70% after more than 10 gray. And you can see here that if they got chemotherapy, CED, cyclophosphamide equivalent dose of more than 20 grams, then the likelihood of having premature ovarian failure is quite high. Almost everybody, by the time they're 40 years of age. Okay, so now we talk about secondary cancers. And obviously, secondary cancers are perhaps the most disturbing problem of all. And what you can see, what we're going to look at here on the left are malignant brain tumors, gliomas, and on the right are benign meningiomas. And you can see as the radiation dose increases, the relative risk of a second cancer increases on the vertical line for both. And then you can see the EAR is excess absolute risk. And excess absolute risk after 50 gray to the brain is about 4% at age 50. It's about 11% at age 75. And these usually occur quite soon. I'll show you a graph about that. Meningiomas occur indefinitely, and that is over the lifetime of the patient. Again, the higher the radiation dose, 20, 30, 40 gray, the more the risk. But realize these risks are quite small. I mean, this is less than 10% here, relative risk. I mean, less than 10 relative risk. And here it's also about a 20% relative risk over time. So not a big risk. And here you're seeing secondary lung cancers. Now, these are also very uncommon. You can see the excess relative risk after 50 gray is only 0.7% at age 50, although it does increase to 15% at age 75. After lower doses, it's a much lower risk. But the problem with lung cancers is when they occur, they're quite deadly. So they're very worrisome. But you can see here, the more radiation dose, the somewhat increased the risk is, although still uncommon. This is a secondary sarcoma. Sarcomas can also be deadly, so we worry a lot about them. This is the radiation dose on the bottom horizontal line and the excess relative risk on this vertical line. And after 50 gray, it's about 0.3% at age 50 and 1.2% at age 75. So these are very rare. So, I mean, even though we worry a lot about them, they are very uncommon. And one of the problems is the chemotherapists, the pediatric oncologists will tell you, oh, they're all going to get second cancers. You know, we can't give radiation, but they're not going to die of their second cancers in all likelihood. They're going to die of the primary cancer that is the problem. And that's really all the side effects I've been talking about. These side effects are all problems, no doubt. But the biggest problem is the cancer. And the side effects, we need to do our best to minimize the risks, and we need to do what we can to deal with them. We're going to talk more about that. Okay, this is a very interesting finding. So the median latency, the median time for the malignant brain tumors is about 10 years. The median time for meningiomas is about 20 years. The median time to develop a sarcoma, if you get one, is about 10 years. But the median time for a lung cancer is almost 25 years. And this is shown here on this graph. The purple are the meningiomas, the red are the lung cancers. They take a long time to develop, whereas the gliomas, the malignant brain tumors, they occur much shorter latency time. Okay, so now I'm going to summarize all of this data in the next few slides. So if we look to see whether or not the age of the patient, when I started this in 2013, what I wanted to understand was whether the age of the patient is relevant to the likelihood of a late effect. That is the vulnerability to injury from radiation. And we were able to show for these organs that younger age increased the vulnerability or the sensitivity to getting damage. For the brain, for the muscles and the bones. I didn't show you all this data because I couldn't, we had 19 different systems and I couldn't show you all 19 systems. You'd all fall asleep and it would take too long. But for the bones, obviously the younger you are, the more likely the radiation affects growth. For dentition, tooth development, the younger you are, the more likely radiation would cause damage. For the hormones, it's the growth hormone that is affected more if you're younger. We showed you how hearing is more affected if you're younger. If you are radiated when you're very young to the breast tissues, that's more likely to cause problems than if you're older. Turns out that when you irradiate the whole liver, more likely to have problems when you're younger. And we only looked at the 4-second cancers, but both meningiomas and sarcomas, those were more likely to happen in children when they were irradiated at a younger age. Now, we also found that for a couple of situations, the older age increased the likelihood of problems. So hypothyroidism and ovarian function, the older you are, the more likely you're going to be affected. The younger you are, the less likely. And then there were some organs where whether you were a child or an adult, it wouldn't really matter. The eye was about the same in children and adults. We have a paper on comparing these all in that issue of the journal. The head and neck, salivary function, myelopathy, the likelihood of spinal cord damage, lung damage from radiation, renal problems seem to be the same for children and younger versus older. Although we do need more information on some of these. We may find that if we look in greater depth, we're going to uncover that kidneys are sensitive, but we don't have that data yet. The testes, we're studying the testes right now. Our paper on testes did not show that younger age was more damaging, but we're studying it right now. And we're also studying reirradiation, but we did not see a difference in children versus adults. And then now I'm going to summarize what we learned about chemotherapy because it's so important. Because the chemotherapists keep blame everything on radiation, and they just don't have enough information to be able to do that. We found, for example, that methotrexate was similar to about 6 gray of radiation. We found that for the spinal cord, the likelihood of causing damage was about 50 gray without chemotherapy, but about 40 gray with chemotherapy. For the heart, I didn't show you the heart, but the heart, you see valve problems, heart attacks, pericarditis, and each 100 milligrams of anthracycline was about the same as 10 gray mean heart dose. So anthracyclines were, if anything, more likely to damage the heart than the chemotherapy. Than the radiation. We already talked about the ovaries, how that was affected by chemotherapy. And we also already talked about how the kidneys were affected by chemotherapy, particularly ifosfamide. And we found that it was about 63 grams of ifosfamide was about a 5% increased risk in the absence of radiation. Hearing, we showed that about 300 milligrams per meter squared of cisplatin was about the same as 7 gray radiation. And both anthracyclines and alkylators increase the risk for secondary cancers. We actually have a big study group now looking at anthracyclines increasing the risk for breast cancer. And it's clear that they do, and we're trying to define how much. But it was about a 2-fold increase for anthracyclines and alkylators. Okay, so what are some of the knowledge gaps? What don't we know? Well, there's much we don't know about the genetics of the patient. We need to understand more about the radiation volume treated, the fractionation. We talked a little bit about fractionation. This is very important. We need to know more about how diabetes is developing later in life, or hypertension, or metabolic syndrome. Do these damage the vasculature and increase the risk for premature senescence in the child who has been exposed to radiation? So if you, for example, the optic chiasm was irradiated to 55 gray, maybe they're fine, but maybe when they become 40 or 50 or 60 and they have diabetes or high blood pressure, maybe all of a sudden they begin to lose vision because the vasculature is more fragile and the long-term side effects from the radiation begin to show up. For each of our organs, we don't know enough about the kinetics of the toxicity. That is, how long does it take for the damage to occur? Does it plateau? Does it stabilize after a few years? Or does it get better? Does it improve? Is there some recovery? Or does it get worse and worse and worse? For many of the organs, we don't have that information. And we need very, very long-term follow-up data. And we understand that some treatment effects are more problematic than others. For example, heart problems, lung problems, cancers can cause people to die. But infertility, problems with thinking, IQ, losing hearing, these are a horrible problem. Short stature, they're horrible, but they don't kill people. They alter their lives. They're life altering. So some are deadly and others are just really problematic. And so ideally, we know, this is an example looking at the chest and different organs in the chest, the heart, the lungs, the esophagus. If we understand for each organ what the risk is, here's the radiation dose and the estimated risk of a problem. If we know the risk for each organ, and we can have artificial intelligence or our own intelligence tell us we shouldn't worry so much about hypothyroidism, even if it's a high risk, but we better worry a lot about heart damage, even if it's a lower risk, because the heart's more important than the thyroid gland. So when you make decisions about how aggressive to be, you need not to look at the risk to the thyroid gland as much as the risk to the heart and secondary cancers, for example. We need to do this for all of our patients. We need to have ways of computing for each patient we do what the relative different risks are, and then we make decisions based on that, not just arbitrarily. And so there are several solutions. The things that we need to do, we need to disseminate all of this information. We would ideally like to form a center that would coordinate late effects research all over the world, but that would take a lot of money, including data managers, people who model data, and all kinds of computer resources. And not only do we not have that, but the United States is showing its stupidity by making it more hard in our country to support research. I won't go into it, but suffice it to say that we would need money to do this. And then we need to do a better job of gathering data and analyzing it. Now, we do have some future directions. One is called Pentec. this is pediatric hypofractionated late effects. In other words, we want to look at stereotactic body radiation, and we want to look at surgery, SRS, and understand what the long-term side effects of radiation are when you use hypofractionation, which is more likely to cause problems, as you all know. So we use it in very selective situations, usually for metastatic disease. The high-tech that I showed you at the very beginning, the high-tech project, that issue of the journal did this in adults, we need to do it in children. We are studying re-irradiation in adults, but also we now will be doing it in children. We have a big group called the Collaborative Oncology Group for Re-irradiation, looking at this, how much radiation you can safely give when you give radiation a second or a third time. So we call it Pentec Re-irradiation Collaborative Oncology Group. And then we have distributed internationally, all over the world now. We made a list of 80 different possible endpoints that could be studied for long-term side effects. Some of the things I just mentioned. What is the kinetics? How often? Not only how often does it occur and what dose does it occur after, but how long does it take to develop? Does it get better? Does it get worse? All these things still need to be understood. And so we listed 80 different possible endpoints, and our group will act as a forum to discuss projects. So if you have something in mind, you try to put something together, we can at least give you some advice on what we think will be necessary to make it successful. So we will schedule conference calls to discuss with you some of your ideas, and we are happy to do that. And I distributed something that Dr. Robles has, and she could distribute it, and that has our contact information. And I just lastly mentioned there are many guidelines to how often should you test for long-term side effects, like the heart or hearing. How often should you do it? For which patients should you do it? I'm on the steering committee for this Children's Oncology Group 1. There are those in the Netherlands and Scotland. There are many of these. For example, in our guidelines, we, for example, look at chemotherapy. And here, this is a patient who has had testicular irradiation or chemotherapy to the testicles. And these are the different chemotherapies are here on the left. The risk factors are here for having problems with a sperm or testosterone. These are the factors that cause the greatest risks. And this is how you should surveil the patient, how often you should do tests, what tests you should do, and this is just some additional information. So, and then we give references. So I will conclude. I want to thank you all for paying attention, and I will I will end by something that Mark Twain said. I mean, all of us have so much to learn, and he said, "It's not what you don't know that hurts you. It's what you know that just ain't so." So all of us need to be humble in what we know, what we think we know, and if we don't know something, then we admit it and we try to learn. All of us need to be curious, and I appreciate the fact that all of us are enthusiastic in trying to help children with cancer. This is a view during the winter from my backyard showing the crescent moon, and this is Venus and Saturn. So thank you all, and I'm happy to take questions, and I'll stop sharing.
Thank you, Doctor. We have a couple of questions here. I know that you have a short time. The first one is, the first question is, which neoplasia would you recommend to be irradiated in protons?
Please repeat that. I didn't understand.
Yeah. You know, in Latin America, we don't have any proton machine.
Yes.
But somebody wants to know which type of tumors would you recommend to be sent to a proton center?
Well, this is a very hard and important problem. when you send your patient somewhere else for protons, for example, then you are no longer seeing them, and the people who are taking care of them aren't seeing them, and they're leaving their homes. So it is quite a big decision and an important decision. And what I want to say is, yes, we don't have protons where I work, for example. And sometimes I will send a patient elsewhere, maybe if they have a brain tumor, for protons, if I think it will really be beneficial. So yes, there is a role for protons, no doubt about that. But all of you are taking, there are 150 people on this call. You are all doing your best to help your children with cancer. So yes, you should talk to them about protons and see if you think it's applicable. The most obvious example are brain tumors, because you're trying to spare the normal brain around the tumor. But you can do a very, very nice job with intensity modulation. If you have an IMRT or VMAT, you can do a very, very nice job. And we don't have a lot of data showing the clinical advantage, the long-term outcome benefits of protons versus photons. I won't deny that I think that we will be able to show an advantage for protons, for example, with IQ over years, but we don't really have that data now. And I don't want anybody to feel like they're not giving good treatment if they don't have protons. If you do your best with the resources you have, if you have the ability to send the patient somewhere and they have the resources themselves to be able to go somewhere, sure, that's appropriate to do that. But I don't think we should be feeling that we're not giving good treatment. I think we're all doing our best. If it's possible to send patients for protons for isolated tumors, where you have to make the judgment whether you think the protons would be helpful. If there's a lot of normal tissue around the tumor, maybe it might be, but there are some situations like, for example, sarcomas, where the edge of the tumor is infiltrative. And if you were to be too precise, you might miss some of the microscopic disease around it. So it's quite a complicated question, but I think you all do your best with what you have. If patients can afford to go somewhere else, then you can consider that.
Thank you. And the last question is, do you consider that the use of techniques like VMAT due the scatter radiation to normal tissue has increased the number of second tumors?
Well, that's another very controversial question. And we discussed that in our reirradiation reports. And so you would think in general that the low dose bath, that the increased amount of normal tissue exposed to low doses might end up causing more secondary cancers. But when we look at any of the curves that I showed you on second cancers, it's the higher radiation doses that cause secondary cancers rather than the lower ones, with one exception, thyroid. The likelihood of a thyroid cancer is maximum at about 20 to 25 gray. And as you go to a higher dose, that likelihood of a secondary thyroid cancer decreases. But for all the other ones, the more radiation, the more likely you get cancer. And so it's the area of the high dose that is the most important in terms of causing second cancers, not that low dose. That low dose might cause a second cancers in a very few patients many, many, many years later. So I would always use IMRT instead of a 3D if I was sparing normal tissues of importance.
Thank you, doctor. We have more questions, but we will send to you by email.
Well, no, I can go ahead.
Yeah. Okay. Do you want one more?
Sure. No, I can take one or two more. Go ahead.
Okay.
Yeah.
Okay. The people is asking about the hypofraction based on the brain tumors. Do you have any scientific relation with the use of hypofraction?
Well, we don't really use hypofractionation for primary brain tumors. We use it for metastases. And that's because we have to be very, very, we're treating we're not treating much normal tissue. We're not treating much normal brain. We're just focusing the dose on the metastasis. So no, the answer is we do not have much data on hypofractionation for brain tumors. And we're hoping to get that data, but no, we do not.
And do you have any recommendation for kids with some genetic disease, with cancer?
We know that the genetic predisposition to some long-term side effects have been worked out. For example, the heart, the genetic susceptibility to anthracyclines, adriamycin, doxorubicin. There's genetic susceptibility to some of the chemotherapies for the heart. We know that there is also some genetic susceptibility for some other normal tissues like bone, like the brain. But most of this has been worked out for chemotherapy more than radiation. So we have very little data for the genetic susceptibility to radiation damage at this time, but we're working on it.
Okay, thank you, Doctor. More or less is the same, the whole question, but we are very happy and be honored to have you here. It's our pleasure, and I want to invite to everybody to join us in the next Congress from PROS, from the Pediatric Radiation Oncologists, that Mexico will be to honor to receive everybody, and it will be in June 2026. Los invitamos a participar en el Congreso PROS, que es la de la Sociedad de Radiooncología Pediátrica Internacional, que se llevará a cabo en Cancún en junio 2026. Por favor, tengan listos sus abstracts para que podamos buscar algún tipo de ayuda y financiamiento. Thank you a lot, Dr. Constin. We are very happy to hear you, and have a nice night.
Thank you very much. It was an honor to be on this in this meeting. I appreciate it so much. Bye-bye.
Thank you, Dr. Costin, for your support. Thank you so much. Gustavo, no sé si quieras dar unas palabras de despedida.
Solamente agradecer el interés de todos los participantes, del moderador, del ponente y de los 163 asistentes a la actividad. Mostró interés el tener que tratar niños, así que eso nos motiva, y estén atentos a la próxima actividad académica mensual que estaremos compartiendo. Tengan todos ustedes muy buena jornada y gracias por estar con nosotros.
Muchísimas gracias a todos por unirse y los esperamos en el Congreso PROS 2026. Linda tarde.
Gracias,
Gracias,
Beatriz.
Beatriz.
Gracias a todos los colegas de Latinoamérica y España. Seguimos en contacto. Gracias.
Muchas gracias.
Hasta luego.